Hi everyone, welcome back to the channel. Today we're going to talk about vital signs. In medicine, vital signs are the very first indicators we check to get a quick picture of a patient's overall condition. Traditionally, there are 5 classic vital signs: body temperature, pulse or heart rate, blood pressure, respiratory rate, and oxygen saturation, or SpO2. Many clinicians now also include a 6th vital sign, pain. Unlike the others, pain is more subjective, but it's still crucial because it tells us how the patient is truly experiencing their illness or injury. Now let's begin with the first vital sign, body temperature, which represents a balance between heat production and heat loss in the body, reflecting how well the body's internal environment is being regulated by the hypothalamus, the brain's temperature control center. The normal body temperature usually ranges from 36.5 to 37.5 degrees Celsius, though it can vary slightly depending on measurement site, oral, axillary, tympanic, or rectal. Time of day, it tends to be lower in the morning and higher in the late afternoon, and individual factors such as age, activity, hormonal cycle, and ambient temperature. When the temperature drops below this range, specifically below 35 degrees, we call it hypothermia. This can happen after prolonged exposure to a cold environment, such as being outdoors in winter or being submerged in cold water. Certain medical conditions can also reduce heat production. In hypothyroidism, the metabolism slows down, so the body generates less heat. Adrenal insufficiency leads to low cortisol levels, impairing the body's ability to respond to stress and maintain temperature. And hypoglycemia deprives cells of glucose, the main energy source for heat generation, causing the body to cool down. Additionally, alcohol or drug use can contribute, because they impair the brain's thermal regulation and cause blood vessels to dilate, leading to more heat loss. Even during surgery in a cold operating room, patients under anesthesia can't regulate their temperature effectively, making accidental hypothermia common. Management of hypothermia focuses on rewarming. In mild cases, passive rewarming, like removing wet clothing, using blankets, and placing the patient in a warm environment, may be enough. For more severe cases, we use active rewarming. This can be external, such as warming blankets or using radiant heat, or internal, such as warm intravenous fluids or humidified warm air. These methods help restore body temperature and prevent further complications. On the other end of the spectrum, when body temperature rises above the normal range, we encounter fever. Fever is generally defined as a temperature of 38 degrees Celsius or higher. It usually reflects the body's response to infection, as the hypothalamic set point is reset upward in reaction to pyrogens such as cytokines. The most common causes are bacterial and viral infections, but fever can also arise from inflammatory conditions such as pancreatitis or from autoimmune diseases such as systemic lupus erythematosus and rheumatoid arthritis. It is also seen in malignancies, for example lymphoma or leukemia, and in drug reactions. Management of fever focuses on surveying the underlying cause, which will be talked about in a future video. Supportive care including hydration and the use of antipyretics like acetaminophen or NSAIDs may improve comfort. Next, let's move on to hyperthermia. Unlike fever, where the hypothalamic set point is raised, hyperthermia occurs when the body temperature rises without a change in the set point. This means the body is producing or retaining more heat than it can get rid of. It can be diagnosed mainly by the history of a trigger, such as prolonged heat exposure in the case of heat stroke, or exposure to certain anesthetic agents in malignant hyperthermia, combined with clinical findings like altered mental status and very high core temperature. These are medical emergencies. They require aggressive cooling and supportive care. The most effective method in heat stroke is ice bath immersion, combined with IV fluid resuscitation to restore circulation and prevent organ damage. If shivering interferes with cooling, benzodiazepines can also be used to suppress it. Now let's move on to the second vital sign, pulse, or heart rate. Heart rate can be measured by palpating over a superficial artery such as the radial artery, or by devices such as pulse oximeters or automated blood pressure monitors. Heart rate reflects how frequently the heart contracts to pump blood through the body and is a key indicator of cardiac function and circulatory status. The normal resting heart rate in adults is usually between 60 and 100 beats per minute. When the heart rate drops below 60, we call it bradycardia. Bradycardia can be physiological. In athletes, a lower resting heart rate is common because their cardiovascular system is well conditioned. It also happens naturally during sleep, when metabolic demand is reduced. But there are many pathological causes as well. Cardiac causes include sick sinus syndrome, where the sinoatrial node fails to fire normally, inferior wall myocardial infarction that can injure the atrioventricular node, and post-cardiac surgery changes that interfere with conduction pathways. Drugs are another important cause. Medications such as beta blockers, calcium channel blockers, and digoxin can all slow the heart rate by affecting conduction or contractility. Metabolic conditions also contribute. Hypothyroidism lowers overall metabolic activity, hypothermia suppresses cardiac excitability, and hyperkalemia alters electrical conduction, all of which can cause bradycardia. And finally, vagal stimulation, for example during carotid sinus massage, vomiting, or severe pain can temporarily increase parasympathetic tone and slow the heart rate. On the other hand, when the heart rate is above 100 beats per minute, we call it tachycardia. Like bradycardia, sometimes tachycardia is simply physiological. During exercise, the body needs more oxygen, so the heart speeds up to deliver it. The same happens in states of pain or stress, when catecholamines drive the heart rate higher. Cardiac causes include myocardial infarction, where ischemia increases irritability of the heart, heart failure as a compensatory response to low output, valvular heart disease, abbreviated as VHD, that enlarges the atria and predisposes to atrial fibrillation, and cardiomyopathies that create structural abnormalities. Certain drugs or substances stimulate the heart, including epinephrine, alcohol, and caffeine. For metabolic causes, tachycardia is essentially the opposite of bradycardia. Hyperthyroidism raises metabolic activity and accelerates the heart rate. Fever increases sympathetic drive, with the heart rate rising about 10 beats per minute for each degree Celsius. And hypokalemia makes cardiac cells more excitable, predisposing to tachyarrhythmias. Other causes of tachycardia include shock, where the body senses inadequate perfusion from blood loss, severe infection, or other critical illness. The sympathetic nervous system reacts by pushing the heart to beat faster, trying to maintain blood pressure and keep oxygen flowing to vital organs. But no matter what the reason is, once you see bradycardia or tachycardia, the key step is to get the patient on an ECG monitor right away. From there, management should follow the ACLS algorithms for bradycardia or tachycardia to guide further treatment. Next, let's talk about blood pressure, which represents the force exerted by circulating blood on the walls of arteries as the heart pumps it through the body. It is a key indicator of how effectively the heart, blood vessels, and kidneys are working together to maintain adequate tissue perfusion, which means blood flow to organs. Blood pressure has two main components: systolic blood pressure, or SBP, which is the pressure in the arteries when the heart contracts and ejects blood; diastolic blood pressure, or DBP, which is the pressure when the heart relaxes between beats. The normal range for systolic blood pressure is 90 to 100 millimeters of mercury, and the normal range for diastolic blood pressure is 60 to 80 millimeters of mercury. When the systolic blood pressure drops below 90, we call that hypotension. But it doesn't always mean something is wrong. Some people naturally run lower. Still, it's important to know the patient's baseline before calling it abnormal. Always check whether the patient is on antihypertensives, because overtreatment is actually one of the most common reasons for low blood pressure. The more serious cause is shock, which means inadequate tissue perfusion. In this case, blood pressure fails to compensate for the body's needs. Signs of shock include cold, clammy skin, altered mental status, and tachycardia. And we also look for objective markers, like elevated lactate, which signals anaerobic metabolism, or low urine output, usually less than 0.5 millimeters per kilogram per hour. Management starts with fluid resuscitation, while at the same time performing a structured shock survey to identify whether it's hypovolemic, distributive, cardiogenic, or obstructive in origin. On the other side of the spectrum is hypertension, which is defined as systolic blood pressure greater than 130 or diastolic blood pressure greater than 90. About 95% of hypertension cases are primary or essential hypertension. This type has no single identifiable cause, but results from a combination of genetic and lifestyle factors, such as high salt intake, obesity, stress, and lack of exercise. The remaining 5% are secondary hypertension, caused by underlying conditions such as renal disease, endocrine disorders, or vascular abnormalities. These are especially important to look for in young patients with persistent or resistant hypertension. Sometimes we encounter hypertensive emergencies in the hospital. This is defined as a systolic blood pressure above 180 millimeters of mercury or a diastolic above 120 millimeters of mercury with signs of target organ damage or TOD, which includes the brain causing headache, confusion, or altered mental status, the eyes leading to blurry vision or retinal hemorrhages, the heart presenting with chest pain due to myocardial ischemia, the kidneys resulting in decreased urine output or acute kidney injury. Hypertensive emergency requires immediate antihypertensive therapy and close monitoring to prevent further complications. There are also certain asymmetries in blood pressure that can give important diagnostic clues. If the arm and leg systolic blood pressure difference is greater than 20 millimeters of mercury, think about conditions that reduce blood flow to the lower body, like coarctation of aorta or peripheral artery disease. In coarctation of aorta, abbreviated as CoA, the narrowing of the descending aorta limits blood reaching the legs, so the arm pressure becomes much higher than the leg pressure. In peripheral artery disease, abbreviated as PAD, atherosclerotic blockages in the lower extremity arteries similarly decrease leg perfusion, causing lower readings in the legs. And if the difference between the right and left arm is above 20 millimeters of mercury, it usually points to a problem involving the major arteries branching off the aortic arch. For example, aortic dissection can involve one subclavian artery, creating unequal blood flow between the arms. Subclavian artery stenosis causes the same effect because one subclavian artery is narrowed. And in Takayasu arteritis, inflammation and scarring of the large arteries can lead to segmental narrowing, again producing asymmetric arm pressures. Next, let's talk about pulse pressure, which is the difference between systolic and diastolic pressure. The normal range is about 30 to 50 millimeters of mercury. When it becomes widened, meaning above 60, it usually means that the stroke volume is increased or that the arteries have become less elastic. For example, in aortic regurgitation or patent ductus arteriosus, blood leaks back into the left ventricle during diastole, lowering the diastolic pressure while the systolic pressure rises due to a higher stroke volume. This makes the gap much wider. A wide pulse pressure can also be seen in anemia, fever, or hyperthyroidism, where cardiac output is increased, and in arteriosclerosis, where stiff arteries lose their ability to recoil, causing systolic pressure to rise disproportionately. On the other hand, when the pulse pressure is narrow, less than about 25, it usually indicates reduced stroke volume or reduced cardiac output. This happens in hypovolemia, where there isn't enough circulating blood, in aortic stenosis, where the outflow is obstructed, in cardiac tamponade, where the heart can't expand properly, and in heart failure, where the pumping function is weak. Now let's move on to respiratory rate, which is the number of breaths a person takes per minute. It is one of the most sensitive indicators of a person's respiratory and metabolic status. Even small changes can signal early deterioration. A normal adult respiratory rate is 12 to 20 breaths per minute. When the rate falls below 12, we call it bradypnea. Neurological causes include brainstem lesions or increased intracranial pressure, both of which interfere with the respiratory centers. Central nervous system depressant drugs like opioids or sedatives can also suppress the drive to breathe. Metabolic causes include hypothyroidism, which lowers overall metabolism, hypothermia, which slows down physiological processes, and high levels of potassium or magnesium, which can depress neuromuscular function. Pulmonary causes often relate to weakness of the respiratory muscles. This happens in neuromuscular diseases such as Guillain-Barré syndrome, abbreviated as GBS, amyotrophic lateral sclerosis or ALS, or myasthenia gravis or MG. It can also occur in restrictive lung diseases such as pulmonary fibrosis, where stiff lungs make it harder to generate breaths. Other causes include post-anesthesia, where residual sedatives and muscle relaxants can keep the respiratory drive suppressed. On the other hand, when the respiratory rate goes above 20 breaths per minute, we call that tachypnea. Neurological causes include central nervous system injury, seizures, or encephalopathy, where abnormal brain activity increases the respiratory drive. Metabolic causes include metabolic acidosis, where the body blows off extra carbon dioxide as a compensation, and hyperthyroidism, where an overactive metabolism speeds up breathing. Pulmonary causes are very common. Conditions like pneumonia make gas exchange inefficient. Pulmonary embolism limits blood flow through the lungs. Congestive heart failure causes fluid buildup, and diseases such as asthma or COPD obstruct airflow, all leading to rapid breathing. Other causes include pain, which can trigger fast breathing through stress and sympathetic drive, and shock, in which the body tries to deliver more oxygen. For both bradypnea and tachypnea, the first step in management is to give oxygen supplementation to stabilize the patient and simultaneously perform a thorough survey to find and treat the underlying cause. Now let's talk about oxygen saturation, or SpO2, which represents the percentage of hemoglobin in the blood that is bound with oxygen. It indicates how effectively blood is being carried from the lungs to the body's tissue, a key measurement of oxygenation status and respiratory efficiency. It's measured non-invasively with a pulse oximeter, usually placed on the fingertip. The normal range is 95 to 100%. When the SpO2 drops below 95, we call that desaturation. The next step is to check an arterial blood gas, which tells us what type of respiratory failure we're dealing with. Type 1 or hypoxemic respiratory failure is when the PaO2 or partial pressure of oxygen falls below 60, while the PaCO2 or partial pressure of carbon dioxide remains normal or low, under 45. This means oxygen is not getting into the blood properly, even though ventilation may still be adequate. Type 2 or hypercapnic respiratory failure is when PaCO2 is elevated above 45, often with low oxygen as well. This tells us that ventilation is impaired, so carbon dioxide is not being cleared effectively. To further identify the mechanism, we look at the alveolar arterial gradient, or AA gradient. This is simply the difference between the oxygen pressure in the alveoli and the oxygen pressure in the arterial blood. A normal AA gradient means the lungs are transferring oxygen normally, while an increased AA gradient means there is a problem with oxygen transfer. In type 1 respiratory failure with an increased AA gradient, the causes include VQ mismatch, meaning ventilation and perfusion don't match. If ventilation is impaired, like in airway obstruction or alveolar collapse, the ratio drops. If perfusion is blocked, like in pulmonary embolism, the ratio rises. Diffusion limitation, as in pulmonary fibrosis, where thickened alveolar walls slow down oxygen transfer. Right to left shunt, where deoxygenated blood from the right side of the circulation passes into the left side without being oxygenated in the lungs, and therefore mixes with oxygenated blood. It can happen intrapulmonary, as in acute respiratory distress syndrome, or ARDS, where alveoli completely collapse or fill with fluid, preventing ventilation even though blood flow continues. So deoxygenated blood passes through the lungs without being oxygenated. Or it can happen at the cardiac level, such as in a ventricular septal defect, or VSD, where blood directly crosses from the right to the left side of the heart, again allowing deoxygenated blood to mix with oxygenated blood before it enters systemic circulation. In type 1 with normal AA gradient, the issue is usually low inspired oxygen, such as at high altitude. Type 2 respiratory failure typically does not show an increased AA gradient, because the main problem is hypoventilation rather than oxygen transfer. This can be due to neuromuscular weakness or central nervous system depression, which we already mentioned earlier as causes of bradypnea. Oxygen supplementation usually helps in most types of respiratory failure, except for right to left shunt, where the blood bypasses the ventilated alveoli entirely. Finally, let's talk about pain. Unlike the other vital signs, pain is subjective, but we still try to measure it with a standardized way. The simplest method is the numeric rating scale, where we ask the patient to rate their pain from 0, meaning no pain, to 10, meaning the worst pain imaginable. What makes pain especially important is that it can sometimes point to life-threatening conditions. Let's go through a few key examples. For headache, you want to watch out for subarachnoid hemorrhage or SAH, intracerebral hemorrhage or ICH, meningitis, encephalitis, or even a brain tumor with increased intracranial pressure or IICP. For chest pain, the most dangerous causes include cardiac emergencies like acute coronary syndrome, aortic dissection, or cardiac tamponade. It can also come from the lungs, such as pulmonary embolism or pneumothorax, and a rare but deadly cause is esophageal rupture. For abdominal pain, think about vascular and surgical emergencies, like a ruptured abdominal aortic aneurysm, mesenteric ischemia, perforated viscus, or peritonitis. We'll go into each of these in much more detail in future videos. And that wraps up our video on vital signs, from body temperature, pulse, blood pressure, respiratory rate, and oxygen saturation, all the way to pain. These 6 parameters are the first clues we use to assess a patient's overall condition. If you found this video helpful, don't forget to hit the like button, as it really helps the channel reach more people. Thanks for watching, and I'll see you in the next one.